Hello everyone, and welcome back to part 2 of our two-part lecture discussing the hemodynamics of exercise. In the first video, we discussed VO2, or the volume of oxygen that our bodies are consuming. And so basically, as you sit here right now, you are burning a certain amount of energy. You have a baseline of metabolism that you're burning watching this video, and I imagine that's relatively low, but to match that level of metabolism you have a certain amount of VO2 or oxygen that you're consuming to match that energy. As we go to exercise, as you go on a bike ride or you go on a run, you're going to recruit more motor units, and more motor units mean that more skeletal muscle fibers are working, and so your consumption of energy, your metabolism is going to go up, and so we match that with the volume of oxygen that we are consuming. And so as intensity of work goes up, so does VO2 until we reach that max limit, right? And so that VO2 maximum is what we use to basically define aerobic fitness. And so when we look at different populations and we look at VO2 maximum, we know that athletes are going to have higher VO2 maximums. And we determined from the last lecture that the reason why they have such higher VO2 maximum is because of their high stroke volume, right? So the first question that we start off today is, why do athletes have such a high stroke volume? And so below you see 3 different reasonings. In actuality, it's probably a combination of these 3. But number 1 is the increased contractility and left ventricular hypertrophy. So just as you go to the gym and you do your bicep curls and your bench press and your squat, you're hoping to build those muscles. You're hoping to see some growth, to get some hypertrophy in those muscles and to get stronger. And so the more you train, that's an adaptation. Those muscles get bigger and they get stronger. And the same thing is true for aerobic exercise. As you are going to continue to go on bike rides, continue to go on swims, continue to go on runs, that's going to be an effect that your cardiac myocytes, the muscle cells, surrounding your left ventricle, they're going to get bigger and they're going to be able to produce more force. And so that increased contractility, independent of the amount of volume of blood that's coming in, that increased strength of contraction, that's going to lead to a higher stroke volume. You're going to be able to eject out more blood, and this translates well for exercise. And so another reason why is because the increased compliance of the pericardium, and the pericardium surrounds your heart, and so it limits the amount of stretching that occurs in that left ventricle. And so an adaptation of exercise, of aerobic exercise, is that you're going to get a lot of blood flow returning back to the heart. And so when you get that increase in preload, those ventricles, they stretch out. And so with that style of training, what's going to happen is that there's going to be an adaptation that pericardium becomes more compliant. It's going to allow a little bit more filling of the heart. And we know that if you're able to fill up the left ventricle more and you're able to stretch out those sarcomeres, that's going to lead to a higher stroke volume. A higher EDV, a higher end diastolic volume, equals a higher stroke volume. And the more you're able to fill up the heart and stretch out those sarcomeres, that's going to translate to a higher amount of force, therefore a higher amount of output. And then a third reason why athletes have a higher stroke volume is because of increased blood volume. If you have increased blood volume, it's going to help build up pressure and build up the ejection of blood. All right, so again, athletes have a higher stroke volume, not only during max exercise, but also at rest as well. And so what you tend to see is that when you're looking at heart rates across different populations, well, a disease state or someone who's very, very unhealthy is going to have a higher heart rate because they don't have the stroke volume to match the cardiac output needed at rest. So in order to compensate, their heart beats more often, more times a minute. And then as you go to an athlete, well, their stroke volumes are so high that they don't need their heart to beat 80 times per minute, right? The amount of blood that they are ejecting per beat is sufficient enough to keep up a high cardiac output even at rest. And so there is a benefit when it comes to this, right? When it comes to physical activity. And so last time we discussed about once you start exercising, you have from rest to 100 beats per minute, that raise in heart rate, that rise in cardiac output is all going to be due to that parasympathetic withdrawal. And since that athletes have a higher stroke volume, right, they're going to have a more dominant on parasympathetic nervous activity controlling their resting heart rate. That's going to translate into some important things when it comes to physical exercise, right? So if we look at these three populations from earlier, an elite endurance athlete, normally active subject, and disease state, or this person had mitral stenosis, right? So the resting heart rate is, probably what you could have predicted, lowest in the trained athlete, a little bit higher in the normally active subject, and then the highest in a disease state. And that means the difference between that resting heart rate and 100 beats per minute, it's going to be significant. So this athlete is going to have way more room, a way higher gap to 100 beats per minute than the sedentary person and then the disease state, right? And in addition to that, they're going to have higher stroke volumes. And so once an athlete goes to 100 beats per minute and you compare that to the other populations, well, that difference in cardiac output, right? The athlete is going to be at 14 liters per minute just at 100 beats per minute, right? And so when you compare that to a normally athletic person, that's 3-4 times what they're able to produce at 100 beats per minute. And for the disease state, that's the athlete's producing 15 times more than they are. And so when you look at it relatively, a reason why athletes are able to handle any intensity of exercise so well is that relatively they have a higher cardiac output even at 100 beats per minute, which if you think about intensity of exercise is not that much. It could be only 40-50% of their maximum amount of effort that they could put in. So already, just at 100 beats per minute, the athlete's at 35% of their cardiac output, while a normally athletic person would only be at 21 or 20%, and then disease state at 10. So this gives an athlete a distinct advantage when it comes to working out and when it comes to intensity of exercise, because they're able to produce so much cardiac output, even just from going from rest to just starting physical activity. And that's going to lead to a great tolerance of dynamic exercise, right? And so we also want to talk about, again, what limits VO2. And we determined based off the previous slides that it's going to be stroke volume. That's going to be the main thing that determines our VO2. And so, where is some proof of that? Where can we see that? And so let's look at some slides here. We're going to assume, so during that VO2 maximum, 80 to 90% of that cardiac output passes through contracting skeletal muscle. And that's a good thing, right? Because first of all, they are the cells that are working, right? They're the ones producing the movement, the ones taking you through that exercise. So you want most of the blood, most of the oxygen being delivered to that skeletal muscle to perform that activity. And another benefit to this is that when you pass blood through the muscle, you get an aid to your cardiovascular system because the muscle pump is going to help return that venous blood back to the right atrium. And so when you increase that preload, it increases EDV and then increases stroke volume. And so where does the pericardium play into all this, right? Because we're concerned about stroke volume because that's the thing that's going to determine VO2. And how do we know that? So here's one example here why. So we have two different groups of dogs, right? One's going to be a normal group of dogs, their pericardium intact, and then one group of dogs, the P here, that's going to be a group of dogs where they had their pericardium removed. And I just told you that the pericardium is going to limit the amount of stretching that the heart is going to be able to, undertake. So, when you remove that pericardium, there's not that limiting factor. There's not that, thing that's limiting the stretching of those ventricles. So what does that translate to? And so again, this is not like a recommendation to remove your pericardium, right? I'm not saying anything of the sort. We're just trying to understand the relationship between the muscle pump, stroke volume, and VO2, right? So both in the dogs, the normal dogs, and then the dogs with their pericardium removed, we see similar heart rates, right? As we go from rest to intensity 1 to intensity 2 to peak intensity, heart rates remain the same. But then as we look at stroke volume, going first, let's look at the normal dogs with the pericardium intact, right? As they go from rest to intensity 1, intensity 2 to peak intensity. And then we see the real difference with the dogs that had their pericardium removed. And what is going on here? Why is the stroke volume so much higher? Well, because you remove the pericardium, the muscle pump is able to fill those ventricles up with more blood. And because we are increasing that EDV, right, we're able to increase stroke volume. And so what does this tell us? It tells us that the muscle pump is actually able to deliver a higher stroke volume than the stroke volume of the left ventricle when that pericardium is intact. And that's why it's not this isn't an example to say, oh, aerobic athletes should get their pericardium removed. That's not it. The pericardium is going to prevent the damage from occurring in the heart. If you had, no pericardium, you're going to see more likelihood of damage and injury to those muscles, therefore damage and injury to the heart. But what it does show us is that, again, it's stroke volume that is the limiting factor in VO2 maximum. Because as we increase intensity, right, we're limited here by the amount of stroke volume that we can produce. We're limited in the amount that our heart can actually fill up with blood. And if we basically remove that pericardium, we would be able to fill up our heart with more blood, and it would be able to eject out more blood, right? So again, that muscle pump is serving to bring back all of that blood, and it is not the thing that's limiting our VO2. It's not the amount of blood that we're delivering to our muscle which dictates our VO2. It's going to be the stroke volume of the heart. It accounts for, it's the actual production of the heart that limits us once we exercise. And so, again, cardiac output and preload, they have an interdependent relationship. An increase in preload will increase cardiac output and vice versa, right? But when you compare when you take the relationship the other way, meaning, sorry, I shouldn't have said vice versa. So when you compare cardiac output and what effects does it have on preload, we've determined when nothing else changes, right? No changes in the vasculature, no contraction of the muscle. When you increase cardiac output, you decrease preload. Why? Because when you are producing more out of the heart, more of that blood is going to go into compliant regions of the body, right? The splanchnic circulation, for one, it's going to hold on to large quantities of that blood. But does that relationship exist during dynamic exercise? And the answer to that is no, because why? We have the muscle pump, so even though cardiac output is increasing, well, if you have more muscles than contracting and sending blood back to the heart, you don't see that same relationship. So whatever the heart is able to pump out, then the muscle is able to deliver it right back. So as long as you have that sympathetic nervous activity that's limiting the amount of blood flow going to compliant regions, again, in order to keep VO2 high, we want to limit the amount of blood going to compliant regions, and we want to increase the amount of blood going to the skeletal muscle tissue, not only because it keeps up the intensity of activity, but it's also going to lead to an increase in preload, which will help increase our stroke volume and then cardiac output. So is stroke volume a limiting factor to VO2 max in healthy individuals? I think you know the answer to this question, and that is yes. And so I want you to pay attention to what is here in the red boxes. So when we define VO2 through the Fick equation, we're going to talk about heart rate, we're going to talk about stroke volume, and we talk about AVO2 difference. And so as intensity of exercise increases, you see that, let's start here with AVO2 difference, right? It's going to continue to go up and go up and go up, all the way until you reach 100% of your output. And the same thing here with heart rate. It's going to continue to increase all the way up until we reach that maximum output. But notice in the first lecture that I said that all factors of the Fick equation must be at maximum, which is cardiac output and AVO2 difference. So that doesn't necessarily mean that as far as cardiac output is concerned, that both heart rate and stroke volume need to be at their maximum. So heart rate is. So as you reach 100% maximal exercise, your heart rate will be at 100% of its maximum. But when you look at stroke volume, and especially this is more so in sedentary and non-athletic populations, you're going to have a peak in stroke volume at around 80 to 90% of your VO2 maximum, right? And one reason for this is because your heart rate has gone so quick that it decreases the amount of filling time for that left ventricle. So that's going to have an effect on your stroke volume. So what we tend to see here in a sedentary and non-athletic population is that it's going to peak at around 80 to 90%. And then, you're going to get less and less time to fill that ventricle. So it's either going to peak out here and stay the same, or may even decrease as you reach towards your heart rate max, right? And so similar, around that 90%, and even though heart rate's going up, you're going to see around 90, 95% that cardiac output max out. And then your AVO2 difference goes all the way up to 100%. And that's where you're basically, that's it. That's going to be your limit for VO2 maximum. So that plateau there, that stroke volume, that's going to limit us as far as VO2 max is concerned. And so this is a little bit different for athletes. There have been studies showing that an athlete, an aerobically trained athlete, their stroke volume will go a little bit more up in a linear fashion and still will plateau around that 90 to 95%. But, still the same thing, that your stroke volume is the thing that is going to limit your VO2 maximum, because heart rate's going to continue all the way up till it reaches maximum at VO2 max, and then so will VO2 difference. And so not only does preload have a relationship on cardiac output, but so does afterload. And so we know that an increase in afterload will decrease cardiac output, and a decrease in afterload increases cardiac output, because that is the pressure that the left ventricle is opposing, right? So if we reduce that arterial pressure, it is able to increase that cardiac output. And so again, these are coupling factors. Preload in cardiac output and afterload in cardiac output. These are coupling factors. They have a relationship with one another. They affect each other. And so an increase in cardiac output does increase afterload. If you pump out more blood from the heart to the arterial circulation, to the arterial vasculature, well, then the pressure in the arterial vasculature increases. And then that's going to make it harder on the next beat, right? Afterload's going to increase, so that may limit then cardiac output on the very next beat. So, sorry, I should probably just get through this. If an increase in cardiac output increases afterload, and increased afterload reduces cardiac output, what happens during exercise? So what this is saying is that, okay, our cardiac output's going up during exercise. That should translate, right, with nothing else changed, for more blood to be on that arterial side, for arterial pressures to increase and then limit the amount of stroke volume, because there is a buildup in pressure across that aortic valve, right? But why doesn't this occur during exercise, right? Because this relationship, this cardiac output to afterload relationship, this is independent of everything else, right? So meaning, let me rephrase that. So this is saying that, that relationship occurs if nothing else changes. But during exercise, we have a whole lot more going on. And so the reason why this relationship also does not exist during exercise is because we get a huge increase in vasodilation and a huge increase in blood flow to the muscles, right? So we're not seeing that increase in TPR, right? That increase in afterload, because that blood that is being pumped out of the heart into the arterial vasculature, it's not staying there. It's flowing through the circulation. It's flowing through the muscle vasculature. It's going from the arterioles through the capillaries. It's moving at a very high rate, a very high flow, right? So you don't see that buildup on the arterial side. And so the effects then of afterload on cardiac output are minimized. So again, those coupling factors, those relationships, cardiac output and preload and cardiac output and afterload, how cardiac output affects those two factors, that relationship does not really exist to the same degree when we are physically active. And so when we look at VO2 maximum, we said that, and you saw in the graphs and figures, that a VO2 difference will increase with increases in exercise intensity, right? And so the difference in O2 in arterial and mixed venous, or we take that from the pulmonary artery, blood widens with increasing VO2. So we start at a relatively low baseline AVO2 difference, and the more exercise, right, the more intensity of exercise equals a higher O2 extraction. So that's around 25% roughly at rest, and then that climbs up all the way to 80 to 85% extraction. So we're taking out a large quantity of oxygen from the red blood cells as we begin to exercise. And how does AVO2 increase? One can be hema concentration, so the concentration of hemoglobin and O2 carrying capacity increased by 10% during maximal exercise. So even though the O2 content remains relatively constant, the saturation falls, right? Because blood is moving quicker. Oh, sorry about that. Uh-oh, okay, lost our place. So here's our resting AVO2 difference, right? The difference between our arterial O2 and our venous O2. And then when we go up to max exercise, right, this gap, it really widens. And so one thing is that why is this going to get bigger, this arterial amount of oxygen? One reason is because that we're taking in more air when we exercise. We are, seeing more volumes of air entering our lungs, and with that air becomes a higher pressure of oxygen. And also, since we have more oxygen, higher partial pressure of oxygen coming into the system, that's going to translate to more oxygen being diffused through those pulmonary capillaries. And then also a reason for this gap is because our mitochondria, they're more active, right? So we're redistributing the blood to more active tissues, whereas here, we may not actually be using a lot of that oxygen that is being passed by. Well, now when we send 80 to 90% of the blood to the skeletal muscle, well, they're working at such a high intensity that they're going to use every single bit of oxygen that they can to keep on performing that physical activity, right? And so since the mitochondria are, using up that oxygen, that difference between the arterial blood and then the cells, that difference in O2 is going to be high. That pressure gradient is going to be bigger. And that translates to more extraction, to more dump off of oxygen from the arterial circulation to the cell. And then when you look at it afterwards, that venous O2 is going to be a lot less, right? So again, that pressure gradient from diffusion, it increases as we increase the work that the mitochondria is doing, right? So not only are we getting more oxygen into the system, but we're utilizing more oxygen as well. And so that concludes our part 2 of our lecture here concerning the hemodynamics of exercise and our cardiopulmonary system through, or what's going on during physical activity. So we will continue in the next lecture, and we're going to talk about skeletal muscle blood flow. What allows more blood flow to the skeletal muscles during dynamic exercise? Thank you guys so much, and I'll see you next time.